Good evening. Thank you to each and every one of you for being here with us today. We are very pleased to be able to welcome those of you that have been with us for a long time now, as well as those who are new to the Academy of Science family. This year marks the 65th year that we have been actively engaged in the scientific community in New Jersey. Despite the challenges we face this year, as a team, the New Jersey Academy of Science Board managed to convert our annual research meeting into a virtual research competition. In this manner, we continue to showcase the outstanding scientific presentations from high school, undergraduate, and graduate students. In addition, this summer, we are hosting multiple virtual seminars to engage, inform, communicate to our members about current scientific highlights. Before we get started, I would like to express my sincere appreciation to all of you who graciously donated to help us make this event a success. Dr. Rosie James, Ms. Megan Lavelle, Ms. Nan Pettigo, Dr. Michael Leah, Ms. Gaia Amitavazar, Ms. Bridget Brown-Eustache, Ms. Dija Kakumba, Ms. Roma Morris, Mr. Ferres Nalazet, Mr. Luigi Cordova, and Ms. Linda Anthony. We couldn't have done it without you. Today, we are proud to be able to host a close-up with New Jersey COVID-19 heroes. There is so much information in the media about COVID-19, but actually hearing true stories about what healthcare providers went through while information of COVID-19 was limited is essential. I hope we all can get our questions answered by hearing their stories and understanding why wearing a mask is so important. Well, I don't want to take too much of your time. I need to leave some time for the two hosts of the evening, Ms. Radu and Ms. Cho, who are the New Jersey Academy of Science Social Media Associate Directors, and they will be introducing the speakers for tonight. So a very warm welcome to each and every one of you. If you have any questions, suggestions, clarifications, or just want to say hi, you can post it in the chat mode. Thank you very much for listening, and let us welcome Ms. Erica Cho and Ms. Natalie Radu.
Hello, everybody. So with us today, we have Dr. Rory Ulloque, who is a medical director at a non-teaching hospitalist program, as well as the medical director of a post-acute care program. He's also an associate professor in the Family Medicine and Community Health Department at Rutgers University, and he led 15 COVID-19 teams at Robert Wood Johnson Medical School, which is also associated with Rutgers. We also have Dr. Lisa Primiani, who is an attending physician and also works at MedExpress Urgent Care in Northern Jersey. We also have Dr. Tamara Beckford, who is an emergency medicine physician and has a rather unique perspective in the regards of the fact that she works at Houston Methodist West Hospital in Texas.
We also have Ms. Mariana Restrepo, who works at Robert Wood Johnson University Hospital during the pandemic. She also has extensive experience working in the respiratory care units of 2 hospitals. We also have Ms. Aradia Tabasko, who works at the Central Jersey Emergency Medicine Associates, and with her perspective, we can get new information and also information on what it was like working during the COVID-19 crisis. So all of these healthcare providers have played an integral role in managing the effects of COVID-19 in the medical field. We're going to first ask a couple of general questions for each speaker to answer, and then we're going to ask each speaker a personalized question based on their experience and background. We will also leave time for questions at the end for the general audience. So the first question will be, what are the biggest challenges you faced during this pandemic? Dr. Ulloque, would you like to start?
Sure. First of all, thank you for having us. Thank you for putting this panel together. And I hope that we can have a productive, engaging, and a good interactive discussion given the circumstances. So I mean, there were a lot of challenges, both professionally and personal challenges that we faced during the epidemic, and we continue to face now, right? Um, from a professional point of view, when we got hit with the first wave, and I'm gonna keep on emphasizing the first wave in New Jersey because we don't know what's going to happen down the line. We were dealing with a novel virus, novel disease, and with limited literature. And we were treating patients and with basically, to the best of our abilities, with no scientific data that can tell us what the standard of care was for this particular virus and for the treatment of the complications. As we've emerged over the last 3 or 4 months, we've begun to understand the pathophysiology of the disease a lot better. So we've been able to come up with treatments on an inpatient, outpatient setting, which have been pretty effective. And they've helped us save many lives, across the tri-state area and hopefully now in the country. From an administrative point of view, I think, one of the biggest challenges, and you guys heard the news, was obtaining PPEs, which is personal protective equipment, for our staff, nurses, and for everybody that was on the front lines. It was a challenge, dealing with, shortages of PPE in the area. Whether it was isolation gowns, N95 masks, goggles, face masks, etc. You know, the state and the administration did help us, achieve that, and they helped to at least at Robert Wood Johnson University Hospital, where I do part of my work. They help to keep us safe, all while treating, patients. And then from a personal point of view, despite putting in the long hours, I guess one of the hardest things for me, and to this day, they continue to be the hardest things, is, not being able to communicate with patients' family at the bedside. So we were seeing patients, various levels of the disease. Some of them sicker than others. Some of them, not doing so well. And telling family members, having that conversation every day about your husband, your dad, is not doing well, or they're not reacting to treatment, and having that conversation without them seeing their family members at the bedside was really, really hard. And I continue to have those conversations now because of the visitation policies at the hospitals. And it never gets easy, right? And it's hard to separate yourself from what you're taught to do as a physician versus what you have to do as a person. And that's it continues to be a challenge on an everyday basis. Whether you see a patient the first time, or whether you see them the last time, at the deathbed, the experience is always, it's never the same. We count on those interactions, with patients' family in order to bring closure to the experience, and we continue to lack that because of the, as I said, because of the, visitation rules and social distancing and everything else that the state has come up with. So those are my stories for now.
Thank you so much. Would any other speaker like to follow up?
I can add on to that. Again, thank you, as Dr. Ulloque mentioned, for having us. This is an honor. And I think educating ourselves and learning from different providers and different speakers helps us. I work as a primary care doctor and also at an urgent care. And initially when we got this information about COVID-19, it was daily information that was provided to us. So patients would come in, and again, the screening process would be different from day to day, depending on the symptoms that the patient had. And the symptoms initially was cough and respiratory issues initially when we saw COVID patients. And as weeks then progressed, we had to screen COVID patients that had, sore throat and different GI or stomach issues. So the way that we saw patients and the way that we treated them, of course, as a physician, we treated them the way that we were taught in medical school, but the way that we kept to the safety of if there was an exposure of COVID to either ourselves or our coworkers or to other patients in the facility. So at MedExpress, they set up different protocols, which was challenging at first because who was the person that was going to stand at the door and screen patients? So initially there was one designated person that would give a patient a mask and introduce themselves. And then there were different protocols that were put into place where patients were screened over the phone and we were provided with information. As this wave continued, MedExpress also designated special sites for screening for COVID-19, and the testing was limited. As a primary care doctor, I took on telemedicine where I had the healthy, the healthy patients that were worried about the information that came across on the media every day. And they would make appointments just for, symptoms of anxiety or, symptoms of, nasal congestion where, they were seeing these symptoms that could have been related to other symptoms, but they were all concerned about COVID-19. So I saw a lot of patients within the urgent care that came to get, quick care, and then also trying to manage when patients really needed to be seen or they could be screened over telemedicine. And now we're seeing that a lot of patients and a lot of physicians are using telemedicine to communicate with patients. In my personal experience, I feel that it takes away from that point of examining a patient and really coming up with those physical findings. But I see that we're dealing with that right now, and possibly this is the way of the future in healthcare. On a personal note, my challenges, I'm a mom. I have older parents. I was afraid to come home and care for my children. I was also homeschooling. So on a personal note, I was taking on that responsibility as also being, dialing in to seeing my patients. So people would dial in early on in the morning, and that was also, juggling that. There's that disconnect with medicine right now. I hope that everyone is fearful, and that's sort of, it puts doctors in a position where we have to be the strong voice and also sort of be a strong voice for our family. So as we continue, hopefully on this, this conversation, we'll, continue to put protocols and improve what hopefully the second wave or not the second wave has in store.
Thank you so much.
You're welcome.
Would Ms. Tabasko or Mrs. Restrepo want to add?
Sure. Yeah, I'd love to chime in. Thanks for having me. This is really an honor. It's something that I think is a great conversation, a great idea, and I'm really happy to be a part of it. So I work in the emergency department. I work in two. I work at Central State in Freehold and also at St. Peter's, New Brunswick. It was very interesting to work in two places because they were hit by COVID in very different ways. At Central State, we were hit more like New York was early, and then St. Peter's was more like North Jersey, which they got hit later, but it's still just as hard. At Central State, we had the second death in the state, and our first family that came in, who were very vocal and very public about everything, really kind of showed us how dangerous this is. We went from, you know, going to work and not wearing masks everywhere one week, and the next week in full PPE at all times. I would have to agree that it was very hard to have patients come in alone. It was very difficult to watch them go through this very bizarre disease process and not have somebody with them or have to explain to their family members over the phone. That was very hard. Also personally and with our team members, it was very difficult. Just, we were concerned about bringing it home. Looking back on March as compared to now, it's very interesting because I feel like we've kind of gotten the hang of it. In the very beginning, it was day by day, we were doing different things, but now we know, you know, we have to wear PPE, PPE works, you know, we take our time, we do the right thing, and hopefully, you know, we will be able to face whatever's coming at us with knowledge and wisdom, and hopefully be able to have a better outcome.
Thank you so much for your perspective. That was provide valuable insight. Mrs. Restrepo or Dr. Beckford, would you like to add?
I can speak. So I want to say thank you to Maria for having me and to the New Jersey Academy of Science. I am a nurse that was working at Robert Wood Johnson at the time in a respiratory care unit. And as many of you have said, very similar situation I experienced, where I felt like one of the challenges I faced was providing care for a patient that was honestly on their own and was only communicating with family via FaceTime and at one point my cell phone, because the hospital didn't have the proper equipment to communicate with the patients through an iPad. Eventually the hospital did, and that was how we were getting information to family members. It was also difficult telling patients, families, that your dad is stable, your mom is stable this morning, and then, you know, 2 or 3 hours later, they're no longer so stable, and having to relay how that can happen. Like, how do you go from telling me he's stable to not being stable? That was a challenge I faced, as well as trying to keep the distance from, you know, my work and coming home, and trying not to spread it to my husband's parents, who are elderly and also live in the house with us, my mom as well. So those were things that you know, we kind of tweaked as we went.
Mr. Restrepo, you and Ms. Tabasko had similar experiences in the regard of you both worked at 2 separate hospitals at the same time. Did you see a contrast in the way the 2 different hospitals were hit?
So I'm recently rehired to Hackensack. So Hackensack had already gone through their boom of COVID patients. I'm not working in a COVID unit right now, so I really didn't have the experience of COVID patients in Hackensack the way that I did at Robert Wood Johnson. And we started off, I worked a respiratory care unit, so that's where most of the patients were being assigned. So I can't really speak for 2 hospitals. I can only speak for one. The situation with PPE was also dire. My entire career, I've been taught you only use an N95 once. You get rid of it, it's single use. A gown is single use. You actually have infectious disease people walking around, you know, informing you if they see something being used twice. And we went from that to being told at one point that we were going to sterilize our mask up to 20 times, which would mean, for me, I work 3 shifts a week, so you figure numerous times. And then as supplies became more available, the hospital went ahead with just sterilizing them 3 shifts. So that was something difficult too, because you hear so much mixed information about whether or not you were actually being protected after a mask was sterilized the one time. So a lot of unknowns during this time.
Yeah, thank you so much. Ms. Tabasko, you made your own masks, right?
I made my own scrub caps.
Oh, okay. I'm so sorry. I heard that you were making.
Fine. Actually, we had a lot of great community support. We had a lot of people who would make masks for us. So every day we had to get our temperature checked when we walked in. So they would have a whole basket full of them and we would have them. But I really wanted to keep my hair covered, and a lot of people started to do that. We would dress as if we were going into the operating room. So we did the scrub cap. So I'm crafty a little bit. I like to crochet, but I'm not really much of I can't really sew using a sewing machine, but I figured it out. And so we had we did the scrub caps and we put buttons on them so the masks didn't bother our ears. And it was nice to kind of have that community, that sense of community, like, hey, we're all in this together. We're going to figure it out. And we're going to get through this. And we still do the same now. I still wear them. Most people do.
I love that.
Yeah.
That's so wholesome.
Yeah, it was great.
Was there a high, I guess, community contribution at any of the other hospitals?
I guess maybe I'll go, if that's okay with you guys.
Yeah, that'd be great.
So I am in Houston, Texas. So as opposed to my colleagues, they're all in New Jersey. I am Dr. Beckford. Sorry for the miscommunication. I was using my husband's computer, therefore it went under Eldon. So I probably will say I'd like to answer a part of the first question, if it's okay with you guys, pertaining to some of the concerns and the biggest challenges. So as opposed to up north, if you guys are watching the news, you realize that Texas, we are going through our surge right now. So I think our challenge is a little bit similar to the north. However, we have the fatigue from the north, but going through the challenge of dealing with the COVID surge right now. So yes, you're tired, but because everyone's been home, and so they've been home for 3 months, they went out, and then now they're being told to go back home. And but now there's a surge. Everyone's dealing with, do I feel like this is, I guess, the population, I should say. The population is like, do I feel like staying home? I've been staying home this entire time, but us as healthcare providers, we're trying to urge them, please, 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 please stay home. Just give us a try. Allow us to be able to get through this, please. And that has caused some fatigue within the healthcare community. Similar to my colleagues here on the panel, there was also big concern pertaining to the fear of bringing home this virus to ourselves. I'll tell you personally that a couple of my colleagues and we started to write our wills, when this came out. Now, these are people who are in their 30s, early 30s, and we're like, okay, if we don't make it through this, we want to ensure our families are okay. So this is how serious this is on us, the fact that we've decided to put together our last will and testament because of this novel virus. Each day, as Dr. Ulloque so eloquently stated, you're changes in protocols, changes in how this disease works. Every time we think, okay, we are doing this correct, then the disease changes course. And then you end up having to deal with some of the consequences, which our other colleagues say who are in the respiratory care unit, having to have patients say goodbye to their family members via video, like what you and I are doing right now. It feels very impersonal and it's hard. And you take some of that home with you. Each patient you lose a little bit of yourself also, because you go into medicine in order to save lives. So when you lose a life, it hurts. So that's, I feel, a big challenge that we face, we are continuing to face, and we're hoping that we can overcome later on. So I hope this answers some of your guys' questions.
Oh, thank you so much. That was very insightful. A question I just have for you, or I guess we have for you, is, I guess, were you, because the surge came later, do you feel maybe, I guess, more prepared I don't know, like, were the hospitals more prepared? Was there like a mental preparation, I guess?
That's a great question. So down here, in some respects, there is you do feel prepared because we've learned some of the techniques from our colleagues who have gone through this. But then in the other portions, we end up still lacking things. For example, during the first portion of the surge, where everyone in March, April, the hospital, there was a shutdown, so a lot of outpatient surgical centers were closed, and therefore the nurses were redeployed into the emergency department. So that ended up increasing the amount of nurses that you had to take care of patients. However, we didn't have that many patients at that time. Then everything went back to quote unquote normal, in that the nurses are back to their original areas. But now we have the surge. So now we don't have enough nurse. So, and even though we do have the advantage of knowing, okay, if we do this, we do step A, B, and C, that will help, the manpower was what ended up lacking. So with that, nurses, physicians, you become burned out pretty quickly when you're working and you're constantly there and you're managing patients who are admitted to the hospital in the emergency department. In my head, I'm a doctor. Once the patients are admitted, I would like them upstairs in the room to continue to care so I can take care of the newer patients. But you have the lack of manpower, therefore the lack of space upstairs. So you're taking care of admitted patients and new patients. New sick patient, continued sick patients. So that did cause a little bit of a strain, and therefore that, even though you can prepare for that, you can't truly prepare. So they're getting travel nurses in order to help to reduce some of the burden, which is something also that occurred up north.
I think Dr. Beckford and all the speakers actually are touching upon a really important part of this COVID-19 pandemic that most medical professionals and patients feel is difficult, which is the lack of in-person or family interaction, right, with those patients. So how do you think healthcare and the hospital setting might look like from a year or two from now? And how do you think this pandemic can shape both the healthcare system, but also how the public views healthcare?
If I can just jump in here really fast, and I just want to add to something before we answer that question, something Dr. Beckford said. Hang in there, Dr. Beckford.
Thank you.
It's a long road. You're going to be okay. Trust me. Okay. Remember to take care of yourself too. Take a deep breath. Yes, they're over. All right. Because I mean, yeah, these were long, hard days for me up here, so, they're pretty sure there's as hard for you right now. So just hang in there. You're doing a great job. All right.
Absolutely. Thank you.
So basically, another thing that came about from all of this, was the camaraderie, right? So, and you're probably going through this now, where, the internists are coming down to the ER in a way that's never been done before, right? Because we don't have the best of workflow amongst each other. But we feel your pain, right? And you feel our pain, right? And, we're both looking at each other going like, okay, what do you think should happen here, right? And then everybody's jumping in, and consultants are jumping in, and, in a way that brought us as a healthcare field together. I think that's one of the most important points when the dust settles in Houston. That's what you're going to realize. You're going to realize that, you did your part in history, right? And you did what you were taught to do, right? Your colleagues all stepped up to the plate, and you all worked as a team, right? And you all went to battle together, and you came out of the battle together, right? That's the most important part, and it's a really, really, it's a beautiful thing to, to be part of, under unfortunate circumstances, but it's something that you will never ever forget. So just remember, protect yourself too, all right? So basically on the next question, I think I think that, we're seeing it now, right? So there's a lot of telemedicine that we're going into. I work at Rutgers, with a huge faculty practice. And, the whole faculty is basically seeing patients, via telemedicine. At some point they're going to let us, when they ease the rules a little bit more, we enter into phase 3 of reopening. They're going to let patients come back into the clinics and whatnot. But I think this, we discovered a new means of communicating with patients. I guess that was already in the makings because, a lot of us were going into telemedicine and telehealth. But we really, I think we took that opportunity and we made a huge window out of a little glimpse, right? And that's just going to continue to grow over the years. So I think that's a way that healthcare is changing. If I put my administrative hat on, and Ms. Restrepo can comment on this as well, the hospital at Robert Wood, we had iPads. We were so busy. We were taking maybe 40 admissions a night at the peak. Okay, so divided into 15 teams and only like 10, I think it was a combination of residents, PAs and APNs and MDs. Maybe there were like 6 people in house doing 40 admissions back to back to back to back to back. We all had that hidden thought in the back of our heads, like, what's going to happen to me if I go into every single room, right? And we made the most out of it. I mean, we used iPads also to communicate with our patients, right? So, we would basically, be in the room, we would introduce ourselves, given the iPads, we would do all our detailed histories and all of that via telecommunication. And that could also happen remotely from home. It's innovative ways of basically dealing with volume, right? So you guys hear everything in the news about how healthcare is, it's getting tested, and the infrastructure is getting tested, and we're almost at a breaking point. That can be true, but we've also found ways to, increase our bandwidth, right? And so, and I hope that, if we get hit with the second wave, if we get hit with any other epidemic or pandemic, we'll be more prepared because we've learned our lessons about how to use other means as well. As I said, telemedicine does not replace the patient interaction, but the patients want to see their doctors, just like Dr. Primiani said earlier as well. The patients are going to get sick. That's why we're doctors. That's why we're here, right? And our job is to, be there at their calling so that we can help them, with whatever kind of illness they have. So I think, the glass is half full, in my opinion, right? And I think that we just need to exploit those opportunities that were given to us right now. Learn our lessons from whatever we've gone through and, improve healthcare in that way.
Thank you so much. Does another speaker want to add their perspective and insight into the question?
I can add a little bit of insight, if that's okay. So within the emergency department, this is my perspective, I do see that there were patients here in Texas who were afraid to come to the ER because of the fact that, they did not want to contract this virus. Some of the negative outcome of that are some patients unfortunately stayed home when they could have been taken care of because of their emergencies, such as atypical presentation of heart attacks. Not all heart attacks present with this crushing chest pain that you see on TV, very dramatic. Sometimes it presents with milder symptoms, and that's what we're trained to see and to handle. So now with this pandemic out, I believe that there will still be a fear of going to the emergency department. There will still be people who are afraid that they will go out and contract this virus. And therefore, that's the need that's out there for the telemedicine. However, there are pluses and minuses of telemedicine, as my colleagues have stated, in that there are certain things you just cannot do on telemedicine. However, there are some minor medical urgencies is what we call it, that is best handled via telemedicine. And that will reduce the burden on the emergency departments in the future. So that I do see. So I do see telemedicine be more prevalent. I do believe that us as healthcare providers who are providing care via telemedicine have to train and to educate the public as to the positives and what can be used via telemedicine and what cannot, so that your expectations of the care is at least provided ahead of time so that you can get excellent care for what you need via telemedicine. But when you need to go and see it in person, you go ahead and do so.
Yeah, thank you so much for that. That was great. Does the speaker want to add on?
I mean, I can chime in if you like. I totally agree. I think this pandemic really pushed telemedicine, and we were already kind of there, but now we're definitely there with telemedicine. I know I work in emergency medicine, so telemedicine really isn't something that I see, but I completely agree with Dr. Beckford. I think that is an excellent point, and educating the public as to the appropriate use for telemedicine is a great way to kind of go forward with the momentum that we have now. And I mean, this pandemic tested all of healthcare and our system, and it's difficult, but you know, I have a lot of faith in the American healthcare system. We're smart, we're educated, and we're figuring it out.
Oh yeah, so yeah, it seems like a lot of the speakers agree that telemedicine may be here to stay, which what I'm hearing is might be a good thing in terms of not overwhelming our medical system, healthcare system. So I guess our next sort of question would really be, so as healthcare providers, how is administration or the hospital CEOs, how have they helped you with the COVID-19 patient surges, and what challenges do you think may have happened between like you and your administration, or how do you think that they addressed it, and in the future, do you see it changing in the second surge if that does happen, or them taking the same steps and they did take the adequate measures?
I can speak. I think that one of the things that they've currently been doing is informing people of the status of the hospital, letting us know how many inpatients we have that are COVID positive and the ones that are awaiting results. They've also allowed us, I guess, as more information comes in from the CDC and it's more accurate, that has also been updated on a regular basis. Whereas I feel like in the beginning, none of that information was really available. And if it was available, it varied minute to minute. And so the administration was only providing as much information as they themselves had, which was very confusing for everybody because no one really knew what was happening. I feel like there's a better grip on what's happening now and people are more informed. So in that way, that's changed. And I think it's been helpful.
Yeah. I'll go also. So down here in Houston, our administration started, or administrators, pardon me, they had town hall meetings, which is similar to what we're doing now, which is they had a meeting, and they still do every Thursday at 12, and they keep you abreast as to, as my colleague says, how many COVID positive patients are in the hospital itself, and our hospital has a lot of satellite hospitals, similar to think of how UMDNJ was. You had the North, you had the Piscataway, so you have a couple of satellite hospitals. So we're kept abreast as to how many COVID patients are in each hospital, how many ICU beds are available, and most importantly, which everyone wants to know, the PPE. How many PPEs do we have? Do we have enough for all our providers? Because remember, we have not just the physicians, the nurses, the respiratory, we also have our environmental services people. So they are some of our true heroes, because with each time where we see these patients who are sick and the beds have to be turned over, which all my colleagues know what that means, you know, the environmental service personnel is in there and they're cleaning. So we needed to ensure that we had protective gear for everyone who is handling this crisis. So of course, as we said at the beginning, yeah, we have enough N95. No, we're running low on N95s. Then it went to, now we're using PPEs, but now the PPEs are breaking. So now we're PAPRs. So ensure that you do this and do that. So it's important because use cloth masks. But just keep in mind that COVID is now presenting atypical. So before it was respiratory, but patients who are coming in saying that they can't smell or taste, that's possibly COVID too. So, you know, that's really brought on having us know what we should have ready. Were they prepared with our protective gear? And will they continue to be prepared? So keeping abreast with a town hall meeting has helped me to know what's going on in our hospital versus the state versus our surrounding hospitals. So that's something that still occurs here on a weekly basis. So that's administrative's approach here.
Thank you. It's really interesting hearing from a hospital in Texas versus like New Jersey. So I was wondering if any of the other speakers want to speak on like what their administration has done and what you think worked and what didn't, and how that's going to affect the planning for the possible second wave of COVID-19.
So from an administrative point of view, I am the director of the Hospitalist program, right, at Robert Wood. You know, I have, you know, Dr. Shara Siddiq is my chief, you know, so he's basically the big man on campus, you know, who makes all these decisions, you know, along with the administrators there, you know, and then he passes it on to us, and then I pass it on to my team. I think one of the biggest challenges, like everybody has expressed, you know, was number one, protecting our workers, right? So there's about, I think it's about 40 physicians and 39 APNs and PAs in our program. So we have a program of about 80 providers, right? So the challenge, and it continues to be a challenge now, is obtaining the right amount of PPE for them so that they can go on the front lines and take care of patients. And I'm pretty sure you speak to anybody, you know, across New Jersey or, you know, in Texas or Florida, or whoever, you know, wherever else, you know, COVID has hit, you know, they're going to go through similar problems, similar circumstances. You know, I guess communication is key, right? And telling your staff, you know, that you have a plan for them. Telling the staff that you're fighting behind the scenes to get them what they need, and actually producing, you know, those promises, you know, making sure that they have whatever they need, you know, is key for that. As we prepare for a second wave, you know, I think, as I said, I keep on dwelling on that point, because you have to learn from what went right and what went wrong, right? New Jersey, New York were the first states in the country to get hit with the pandemic. You know, the good thing, you know, I mean, when we got hit, I remember it was a Saturday night when my boss calls me and he's like, "Okay, we're starting to see it. I don't know what the numbers are going to look like. We need to come up with a structure," right? We went from patient number 1 on a Saturday night to patient number 300 2 weeks later. We went from having one team on 2 physicians on a Monday to having 15 teams with multiple physicians, residents, and Ps, etc. 2 weeks later. So one of the most challenging aspects of this from an administrative standpoint was creating that structure, right? And then working alongside with the hospital in order to make sure that the infrastructure that we laid out was carried out on the floors, right? And so as we saw, we submitted to them a plan, right? Like a search plan. And we told them, if we get up to this many beds, or this many patients, we need this many units, right? And we need this many teams. So we color coded it. We went from like green to amber, as we picked up the volume, more and more floors were converted into COVID units. I think part of where the hospital went wrong, in my opinion, is that, they could have communicated a lot better with, the staff. Because some of the floor nurses, when I told ahead of time, hey, we're going to convert your unit into a COVID unit. And they would walk into work, 2 weeks, like a week later, and boom, you go from taking care of patients to all of a sudden taking care of COVID. And the anxiety that sets in when you hear that you got to take care of a COVID patient for 12 hours a day with limited PPE, not knowing what you're doing, it's beyond what you can imagine. I remember when I first walked, I tell everybody the story. I first walked into a room, into a COVID room. I went in all gowned up. My glasses are fogging up. The patient is talking to me. I can hear them. All I kept on thinking in my head was 6 feet, 6 feet, 6 feet. Patient is coughing, and I know better, right? Because I have the PPE. But all I wanted to do was, out of fear, just run from the room, right? And that's something that, that's when your human spirit basically takes over, right? As you learn more about the disease and you know that you're going to be all right, you just jump in and you just do whatever you need to do. But I wish, and I felt like that, as I said, as an administrator, I could only imagine what, the rest of the staff felt like, and I sort of like had the keys. I knew exactly what the plan was. Yeah. And we tried to convey the plan to the staff as we knew more about it. But sometimes things will happen so fast that you just forget to talk to your staff and you just jump in the fire to take care of the patients, right? And so, and I wish we had a little more time to sort of like digest, go back to the staff and say, hey, how are you guys doing? What else can we do for you, right? And I'm pretty sure, everybody's going through this, whoever's surgeon right now, everybody's going through this now. It never gets easy. If we go through a second surge in Jersey, we're prepared. I mean, I'm preparing right now to, staff up teams, so that we can right now just maintain regular medical floors. We're back to normal at Robert Wood, but I mean, in the snap of a finger, that can just go back into a COVID unit. We can just transition every single team that we have right now into COVID teams again. We've already went through this before. We kind of know what to expect. We know how to treat patients better. And we have technology at our disposal, which is going to allow us to communicate better and all of that. But I mean, it's kind of hard to be an administrator because things are running so fast. And when you're on the front lines as a doctor, you're also taking care of patients. You kind of prioritize those patients over everything else that should be done, and there's only so much you can do as a person to stay sane too.
Yeah, thank you so much for sharing your perspective as an administration, especially during this time where so much pressure is really on you. And thank you for also sharing your humanity, the side of you that, patients may not think about right away. Yeah. So Dr. Primiani, oh my gosh, I'm sorry. Primiani, Ms. Restrepo, Ms. Tabasko, would you like to add something?
Well, I want to add on to not working in the emergency room and seeing patients out in urgent care, I worked for MedExpress, which is owned by United Healthcare. And they were very good from the get-go with having nightly meetings at the end of our shift and really implementing protocols. There's many urgent care centers in Northern Jersey. And I said before, there were 3 designated COVID centers, meaning that if you had any respiratory issues, or COVID symptoms, you would have to be seen at those centers. I have to say, again, with the PPE, proper PPE, even for our staff at the urgent care, it'd be daily counts of N95 and gowns and Clorox wipes, which we've had before, and then it became a shortage of even Purell, which that as a physician is our fear, sort of cleaning down our area and sort of not infecting patients if they were COVID patients. As time went on, protocols were put into place. But as I said, initially it was, I think, the unknown where the administrators were followed with the information that they got from the CDC. And as a provider, if I was a doctor on staff or on shift that day, it's really educating my staff members of what, they should look out for. We talk about common sense. During flu season, even before COVID, I saw patients, I remember the last week of February, during flu season, years prior to, I would wear a mask and, still, try to stay 6 feet from a patient. But I guess the fear of COVID and how quickly this pandemic arose was scary for everyone. And as Dr. Ulloque said, that fear went through you, even though you had your proper PPE on. So, right now, from an urgent care standpoint, we had a low, and now we're sort of regaining those patients. A lot of patients call first. We offer them telemedicine visits. A lot of patients are not able to see their primary care doctors. And another challenge I didn't mention is that, when you're at the urgent care, you're acting as a primary care doctor, and you don't have that amount of information of the patient's past medical history. And you kind of are put into a situation where the patient doesn't want to go to the emergency room for, as Dr. Beckford said, as atypical symptoms of, chest pain, but you have to remember that we're looking at those other signs, besides COVID signs that really go into medical care. As we're entering sort of the end of the summer, we are preparing for flu season, and they have started taking protocols of doing testing or even examining patients. We've examined patients outside in their cars. We're probably going to set up tents and set up testing as well as examining patients. So we're not exposing patients coming into the center and sort of trying to flatten the curve. So we've tried to do that and educating people if they really need to see a doctor, that they can use telemedicine for other medical complaints that we would typically see in an urgent care. So
thank you so much. The car thing is kind of crazy. Like the fact the hospitals are literally outside now. Yeah, that's so crazy to imagine, just all the measures that have had to be taken. Mr. Restrepo, do you have anything to add on the subject?
As far as telemedicine goes, I've had the experience of being a patient myself, getting telemedicine services, and I liked it. It was very convenient. Obviously, I'm following somebody that knows me because it was my primary care doctor, but I thought it was very efficient. It worked perfectly. It was smoothest. I obviously wouldn't recommend it for somebody who's experiencing chest pain or a symptom that is obviously necessitating more care, but for a med refill or for something simple, I'm totally on board with it. I thought it was very efficient.
Yeah, it's good to hear. Like, this is the first time I've honestly heard about like the whole telemedicine thing. And I know, that's so cool that I've learned something from this whole experience, and it's just cool to have this conversation. I guess it's very clear that you guys are under high stress, and that makes sense. Like, you're doing heroes work right now, and I guess on behalf of the Academy, we have to thank you like so much for everything you've done for your communities and just everything you've contributed. I guess the question now is, how can we help you? What can we do to make your jobs easier? Can we donate? Can we, I guess, obviously social distance, but yeah, how can we help you guys?
I can say something. The hospital I'm working in now, which is Hackensack Meridian Health, and I think all across hospitals have visiting hours. I think people should be more conscientious about visiting hours. If you were told 11 to 7, one person at the bedside at a time, it shouldn't have to be repeated, only because you're getting in the way of other care or just the idea of keeping numbers under control. I come across that a lot, where family members are in the hospital and they're extending their stay, and that creates an entire uncomfortable situation. You have to get administration involved to kind of get them out of the hospital, and it shouldn't be that way. It should just be understood. So that's something, as somebody who is not in the medical field coming to visit somebody in the hospital, it's difficult on the patients, but there's a reason behind it. That's one suggestion.
I think also, guys, I think that we need to listen to the science. There's a lot of political innuendo out there, and the elections in 3 months. Remember that. Listen to the voices of reason. Okay. So if they're saying wear a mask because we're doctors and we know what it's like, right? Wear a mask because we're young, and thankfully, this disease doesn't target the young ones, the young population. But then you're going to bring that disease over to home, right? To your elderly parents, grandparents, immunocompromised patients, and then we're going to be in trouble, right? Just remember that, that decision to social distance, wear a mask, wash your hands, that should be common sense, all right? If you listen to our politicians, they'll tell you that drinking detergent is going to save you, right? So take everything you hear about in the news with a little bit of a grain of salt. This is a lot of over-exaggeration and over-hype out there as well. But the disease is real. What the doctors from the government, CDC, are saying to you, what the local state departments are saying to you, that's real. What the data is showing you with hospitalizations, intubations, and all of that, that's real. That's not cooked up. That's not going to be made up. And the way that we can help as a community is to social distance and to wear a mask and don't go out in large gatherings. I mean, it's as simple as that, right? We can do this together. I know everybody's cooked up inside. I know there's a lot of financial, financial decisions. That's why, government's pushing a certain agenda, which, it's fully understood, right? The economy is important too. But just remember, you don't have an economy without health, right? You could have an economy and health in coexistence, especially in New Jersey. We passed that first wave, right? And I think that if we practice some common sense public health initiatives, we're going to be okay, but just always be mindful of that.
Okay, I'll step in and add to what Dr. Ulloque said. Down here now with our phase, I am seeing a lot of younger patients. So, Kawe, like we say, beware. So my patient population at this time has been the 20s, the 30s, the 40-year-old, while most of the, I guess, earlier in the phase, you were getting the 60-year-old, because that's what everyone thinks. Oh, this is a disease of, 60 to 65 and up. It's grandpa's disease or grandma's disease. No. I'm seeing the 20, the 30-year-olds, and The part that's also important, what was stated in the reason for the distancing, is because unfortunately, this disease is being brought home to the family and it's spreading within the families. So the patients that I've been seeing as of late, or I see, say, a 50-year-old male, and I asked, do you know or have an idea of how you contracted this virus? Oh, my wife, she's upstairs, she's admitted, she's positive. Wow, how did she get it? Well, her brother, he and his wife. And these are actual patients that I have. This isn't a made up scenario. So it's running through families. And, if we can try to suppress this disease, then you don't have to worry about mom and dad, aunt and uncle, grandma and grandpa all getting this disease. There will be some of those family members that will not make it. And you don't want that for you, for your family, or for others' family. So this is a time where we have to think of not only ourselves, but also think of others. So when we're asking for the social distancing and wearing the mask, yeah, you might be healthy, but you could also be a carrier. One of my last patients that I had has myasthenia gravis. This gentleman, I don't know if he's gonna make it. So he has to be on immunosuppressant medication in order to survive. So his immune system at baseline is already low. His wife tested positive. That evening, he felt sick. That night, he's in the emergency department with his oxygen saturation of 76% out of 100. So this is real. And this gentleman was only, I think, 57, 58 years old. This is real. So it's important that we take the necessary measures, not only for ourselves, but for others within the community. This is a social disease in that we have to look out for each other. That's the only way we're going to get through this, is if we look out for each other and not just looking out for ourselves.
On the topic of it being social, I guess, as medical professionals, what are your thoughts on schools reopening, like that whole timeline, and how it should be done, I guess, most effectively?
I don't think there's a right answer on that one. It's very interesting. I mean, I can imagine, I don't have children, but I can imagine having a young child wearing a mask and keeping the social distancing as we're all recommending. I think it's definitely a hot topic. There is no right answer to that. I think a lot of administrators are trying to do what I've heard and gathered, do half days, do partial sessions. I think we're approaching the time that we have to make the decision. There's not a right or a wrong decision, but I think we have to let people make that decision on their own, and give them the resources to do so.
Thank you so much. Does any speaker with children maybe want to add on? Because you make a really good point, but I think it's useful from a parent's perspective.
I have twins. They're 6 years old. And I definitely believe, going to school is really important. I think it's a social aspect. Homeschooling 2 children, I saw that, they were able to gain the information, but they missed that social interaction, and also teaching a child from writing, and now they're using an iPad or a laptop, or even testing change. So they went through a huge transition as well, and also an emotional change as well, and really trying to explain to them what COVID meant, especially understanding, as parents, as educators, they're always told to wash their hands, after they blow their nose, they should, use a tissue. I don't know how it's going to work, honestly. I know the school that my children attend, they're looking to keep the children confined to the classroom, and lessen the number of children in the classroom to about 10 students. Now, this is a private school. I know the New York, City public schools, they may not have that opportunity to do that because they're larger classrooms. And a lot of my friends are educators, and the fear is, you know, if these children do not wear masks, or children that do have special needs are not able to kind of maintain masks, or children that have asthma or, you know, other conditions and not able to sort of wear the mask. I mean, I know myself, sometimes at work, I'm wearing a mask for 12 hours, and after a while we need to take breaks, and, you know, asking a 6-year-old to do that for 6 hours a day is a challenge. But I guess this is might be our new norm, and segregating children into smaller classrooms. They're taking away a lot of socialization, gym, music classes, the fun things that, you know, we look forward to going to school. So it's still in talks, and I guess we have to just wait until our local officials and governors sort of give us the green light, and we just have to follow along. So I just, you know, as a mom and a doctor, I know we're going to be hit with that flu season, you know, those stomach bugs, and we're, you know, I don't know if, you know, we're going to have to then say your child needs to be home for 14 days in self-quarantine and have a COVID test and wait the days. So I think this is, and, you know, have a documented flu test. And maybe they're going to be taking temperatures at the door every day. So we haven't really, you know, I mean, I've offered some insight, but again, it's sort of, no one has a straight answer. So it's an ongoing conversation.
Well, I also have an 11-year-old at home, right? And he's an asthmatic. He gets it bad during the winter and transitional seasons. And you know, my wife and I just, you know, we keep on debating on what are we gonna do with him. Right? So the school where he goes to, you know, social private school, they haven't given us any insights yet, because our governor hasn't come out with any recommendations as of yet. You know, obviously, I would err on the side of safety here. You know, but then that's, you know, my personal opinion. You know, I wish they had remote learning. That way we can, you know, we can all be at ease. Now, he's an 11-year-old, and just like Dr. Primiani just said, you know, good luck keeping a mask on a poor kid. You know, he has it on for like 20 minutes. He's like, Dad, I'm nauseous, I'm nauseous, I'm nauseous. He takes it off, he puts his hands all over his face, and I could only imagine what would happen if he went to school like that. You know, I really, you know, I think that antibody testing is going to play a big role in the workplace and in the school place as well. You know, I think, like Dr. Primiani also stated, you know, COVID test before you come in, a COVID test monthly to make sure that you're symptom free. Temperature checks every day. You know, I think that's going to be part of the new norm until this thing goes away. You know, but I mean, as far as when to return to school, that all depends on where the spikes are, you know, where the surges are, and and basically what the positivity rate is, right? So, you know, that's something that's gonna, I think, is best determined at the local level. Again, not at the federal level. I don't think it's up to the federal government to say everybody can open up schools when Texas is going through a surge now. You know, it doesn't make any sense. Yeah.
So as my colleagues, Dr. Primiani and Dr. Ulloque, I have 2 children. I have a 1-year-old and I have a 3-year-old. So they're both going to be transitioning to the next, to 2 and 4. But needless to say, try keeping a mask on that age group, right? Especially since if you look at the American Academy of Pediatrics, they have recommended that 2 years and under should not be wearing masks for the risk of suffocation. So, and what my kids are going through, I guess it'll be like the daycare type of school at the moment. And we pulled them out as soon as this occurred in March. And, you know, debating, because as I mentioned, the beginning portion of March through around June, we had very low amount of cases. And then the cases, I started seeing the rise, and lo and behold, a kid at the school tested positive for COVID. So you can imagine the fear, because if your kid is at school and then there's someone there that has tested positive, now you're worried about bringing it from home, but your kid is getting it from school. That's challenging. So I have opted to keep my kids at home. And as we mentioned, the decision, as Dr. Ulloque said, is different at different levels. In New Jersey, your levels have gone down drastically. In Texas, I'm at the opposite end of the spectrum. Our levels are up. Last week, Friday, 10,000 new cases in one day. Yeah, so with that in mind, I've opted to do our best with help of family because it's something that it will be challenging for me to do on my own with my husband and I. So we've had the help of family, and we have opted to keep our kids home. But they're at the age where I do have the option, right? It's not they're not 5, they're not in kindergarten, it's not mandatory. So those are other factors that I have kept in mind that allows me the benefit of being able to save this. My kids are younger, so we also keep that in my decision making.
Well, Mrs. West actually had a good question. Do you guys have any advice for teachers that are maybe nervous to return to work? Just anybody who's also in the education system.
That's challenging. I feel for our teachers. I have friends that I went to high school with who are teachers, and I've heard from others who've expressed a bit of concern. Just like we as healthcare providers want to do the best for our patients, teachers want to do the best for their students, but they also have families. Just how we are concerned and worried, as we mentioned at the beginning of this talk, of how we were worried about bringing home this virus to our families. I'm pretty sure our teachers, have similar concerns. So 100%, I do not have the answer for that. Other than protecting the personal protective equipment, space, limiting the amount of students within the classroom, as Dr. Primiani says, will occur in her school. Trying to come up with creative ways to keep the kids engaged and also to keep them doing things physical. Is as Dr. Primiani said, they're taking away all the physical activity. We need to move. We're a nation that already don't move. We need to keep these kids active. So not just mentally, but they need to be physically active. So there's a lot that has to go in play in helping. And all I can say is that my heart does go out to all our teachers. We're here with you, and we support you in your decisions.
Thank you so much for your answers. Yeah, it's really interesting to listen, especially from my and Natalie's perspectives, considering we're high school seniors. So we, depending on this answers, whether or not we'll go back. And so it's really interesting to hear your perspectives. So we have 15 minutes left, which makes me kind of sad because it was so nice talking to you guys, and time really goes by fast. So we're really grateful for you taking the time to answer our questions, and we just wanted to make sure that the audience feels comfortable asking questions in the chat, because we would definitely like to address those questions as well. So there was a question from Tiffany Morris, who said that New York City set a benchmark of when the transmission rate is 5% in response to schools opening back up. Do you agree with that number? If not, what number makes more sense?
I mean, I think the answer there is we don't know. Right? So 5% is sort of like fine, looks good. 95% means, you're probably not gonna get it. Right? If you look at papers, you're always looking at a 95% confidence interval, right? So, when you publish data and your numbers fall within the 95% confidence interval, your data is a lot more credible, right? So I mean, does that mean that the data is not credible if it's got like a 5% margin? No, right? So, and again, it's not just about the transmission rate, right? Because it takes one person to become sick, and then they're spreading it, right? So, I think the answer to the question should be more like, what can we do in order to protect our kids and our teachers, right? So I think a mixed sort of like protocol where you have your social distancing in place, where you have masks available for everybody that comes in, and where you have face shields, for those that are interacting more than, like teachers, and when there's more interactions with students and with more people, that's something that's really should be considered. Um, just like you go to a supermarket now, and they have the arrows, and they say you can't stand within 5 feet or 6 feet, whatever. We should practice the same thing on on indoors, right? So in the schools, what's the schools gonna look like, right? So the teachers are gonna be there. We have to have less kids, in the school system, right? But how do you make that happen? Do you modify the schedules? Do you do half days, or like a 9 to 12 schedule for some, and like a 12 to 3 schedule for others? I mean, that's something the administration is going to have to play with. I think that as far as like N95s, because I see that question on the board as well. So N95s are more recommended for healthcare workers and for people that have very close proximities to those who are symptomatic. Okay, and so I think that wearing a surgical mask and just doing social distancing is going to be as efficient in protecting you, right? I can tell you that now that my hospital is out of the COVID zone now, right? I'm no longer on COVID teams, so I'm no longer taking care of active COVID patients. Until next week, I go back on that team. But right now, I go into the hospital in scrubs and with a surgical mask, right? And I'm wearing the surgical mask the whole day. And I'm making sure that I practice social distancing with my patients. I'm making sure that I'm in and out of the rooms as quick as I can, and I do as much as I can over the phone. And I'm very vigilant about washing my hands, and staying clean. And I think that this particular protocol needs to be adapted, out of the community, to keep everybody safe. But as far as N95s, as I said, I think N95s is more reserved for people that are front lines and those who are actively have symptoms. Of course, if you're going to come back to school, you're going to be screened every day. So the hope of that is that if you have a symptom, as soon as you walk in the door, you're getting turned around, to keep everybody else safe. So I think that those protocols should be in place.
Thank you so much. I guess you mentioned like people being actively symptomatic. Should everybody, or this is a question from S. Smith, should everybody get tested even if they don't have symptoms? And do you think healthcare is, I guess, equipped to deliver these tests?
Well, I know at MedExpress, a lot of employers want their employees to be tested in order to return to work. So that if they are, working, even if they're working, let's say at starting to open up retail stores, they want to make sure that the patient is not, COVID positive. The trick about the test is, if they come back negative and may be exposed 2 days later, they may not show symptoms once they return back to work. I just think it's all about all those, the common sense about if you're not feeling well. Even this is a question for the teachers. If you're not feeling well, if you have a runny nose, if you're sort of run down, don't push yourself and don't come into work. And even as a young adult, we want to be heroes. We want to be, to do our job, even as physicians. If we're not feeling great, our bodies speak to us. So we have to, take those smart protocols by just having common sense. If we're not feeling great, we should just stay home. And that's sort of what the CDC recommends as well. Also with the schools, I think, common cleaning, sort of the, Clorox wipes, teaching the kids after they have lunch or, at the end of the day, cleaning down the area, and the teachers should do that as well. And also the social distancing as well is something that should also be done. I'm seeing a lot of questions coming in about teachers and, sort of the mixed flexible model in school and being a bus driver. Those are, I don't know if they're going to put up shields, on a bus, like what they've done in, some of at the bank or medical offices, sort of to yield off respiratory secretions. So this is still a talk, and that's in progress. So we just have to see how it goes. But just, following, as Dr. Ulloque say, wash your hands, again, and as I say, if you're not feeling well, just stay home. And you could be a healthy individual, but you may not have the symptoms, as Dr. Beckford said. So we just have to keep ourselves safe and do the best we can.
Thank you so much for your answer. That was a really great answer. We're getting more questions in the chat, and they're very great questions. So the first one is, has treatment of COVID-19 become standardized, or do different hospitals have different protocols to how they treat admitted patients?
I guess I can start off, and then I'll start off on the front end from the ER, and then I'll have Dr. Ulloque, being the internal, can go ahead. So in the emergency department, I think if you really look at the data that's out there, we have protocols, best practices in place, but I still think that each hospital is still doing a tweak of it that is best for their population. So what's worked in hospital A on the west side of town might not be the exact same, but it's usually within line of what can probably work for hospital B on the east side of town. However, some of the biggest, and these tweaks are just minor tweaks, they're not the big changes, because each hospital is trying to do their best to decrease mortality and to decrease morbidity, which is to decrease the amount of sick people who are going to be disabled afterwards and the amount of death. So overall, we're all following the standard, either from the CDC, from UpToDate. If you read the literature there, you'll see in the literature that says these are guidelines, these are not mandates. And that's the thing about medicine. Medicine doesn't truly have mandates. There's an art to medicine, and then there's a science to medicine. So the art is what we learned, and we have this, what we call the gestalt, where something is different about this one patient. Yes, 95% of the patients this works on. However, I have noticed something different with this one patient, and you go with that if what you're doing is not working, and then you save that life. So with that in mind, majority of us are following standard guidelines, but there's still some tweaks that occur. I'll pass it on.
Yeah, I think, just to pick up on the metrics and the morbidity and mortality, right? So those are the big indicators, right? And I agree with you wholeheartedly. I mean, when you looked up at the north versus what Middlesex County was doing, it was sort of like, okay, fine. This is what the papers are showing. This is what you know. This is how you treat a patient. Put it together, boys and girls, right? So, what we did at Robert Wood, was unique in the sense that we had a multidisciplinary approach to running. It actually turned out to be quite beneficial. So once the patients got admitted, they came over to me. My team and whatever teams, the number of teams that we had, would round out at one given point with a pulmonologist, infectious disease doctor, a pharmacist, social worker, palliative care team. Okay, and so basically, if we had questions, we would present these patients to our colleagues. The pharmacist was, oh my gosh, he did such a great job, because his task was to, and again, I got to emphasize this, right? So the way for Italy in February, I was seeing patients in March, all these preliminary papers were getting rushed. Very little evidence was out there, right? And, we were going by whatever was coming out, right? And so, the pharmacist was basically going through, doing literature reviews almost on a daily basis. And he was telling us, this is what they're doing now. This is what the latest paper shows. Maybe it's worth a shot, right? And before, we went by instinct. I went by instincts. My team went by instincts, and the pulmonologists, infectious disease doctors, and the hematologists went by instinct. But whatever we know, right? So we said, okay, fine. There's going to be a cytokine storm. How do you treat the patients in cytokine storm? And then you're going to see patients that are, why are these patients desaturating so fast? Why is the oxygen requirements going up so fast? Why are they crashing so fast, right? So at some point, I think all of us wound up going on blood thinners, right? And then we saw a difference, right? People in the ICU were then saying, you know something? We give this guy's tocilizumab, right? For ARDS, for people that drown, and it stops the cytokine storm. Let's try it, right? Somebody discovered remdesivir in the middle of all this, right? And we were one of the first hospitals and the first ones in the country to try remdesivir. 3 months later, remdesivir studies come out and they say remdesivir works. 4 months later, Solumedro and Decadron studies come out and they say, guess what? Steroids work, right? So, I think what made us unique at Robert Wood was, again, everybody came together. We did multidisciplinary rounds. I don't think it was done in any other hospital in New Jersey, as far as I know. And it showed, right? Because our patients did better. We lost patients, but we saved a hell of a lot more than what we lost. And our metrics showed we had the best metrics in Jersey, right? So, and looking back, like there was a paper that I was reading yesterday or 2 days ago from JAMA. They were talking about, postmortem autopsies, right? And what these guys, what the body is just, once they open them up, they just find clots everywhere, and then that turn on the light, you're like, huh, okay. So no wonder why our patients turned around so fast, because we had them blood thinners from the second we thought that they were decompensating. We were trending inflammatory markers, not knowing where this was going, but we noticed trends, right? It was like being in college again. It was like being in med school again, where you're going by trends, right? And you're trying to put the science together with the physical, with the clinical scenario. And you know what? It matched up. It worked. So it was like a unique experience in that sense, because you're navigating unmanned waters, but you're also using your instincts and you're training to try to save people. And it's good to know that, at the end of the day, the papers that are coming out now are collaborating what we already knew, right? So I just hope that, that papers keep on coming out, the science keeps on advancing, and we're not going to know, and this is good for those of you guys in the South, right? Because we don't know how to cure this disease, right? I can tell you that I'm seeing the fibrotic stages of the disease now with a few patients that are left, right? They're popping pneumothoraces. They're short of a transplant, they're not going to be saved, right? What we do know is how to prevent those complications now, how to be aggressive from the get-go, and hopefully we can work towards the cure down the line. But at least, we have tools at our disposal now that we just didn't have before. So, that's, that answers that question of whether it's become standardized or not, the COVID treatment, right? Everybody adds their own flavor to it. Everybody, we all go by science, but whatever the latest papers show, right? And by experience, right? And I can guarantee you talk to somebody up north, one of your colleagues, and they're gonna tell you a couple of things, and we're like, oh, maybe I should try that, because I know I went through it, and that's how we learn, and whatever we were discussing as a team, as I said, turned out to be right scientifically in the long run.
Great, thank you so much. That was a great explanation to that question. And we're running a little short on time because we don't want to take up any more of your valuable time. So thank you so much for being with us. It's a quick yes or no question, since it's very short question in the chat, and it's, do you think that people are developing immunity to COVID-19?
Yes and no. There's a poll in progress. Is that, can you still hear me?
Yeah,
you're
we
good.
can hear you.
Not quite sure how this works. So I think yes and no. I think we're doing antibody testing, which isn't really, it's basically just giving us data at this point. If you have antibodies, we don't really know what that means yet. We don't know, like, if we are actually getting actual numbers, or if it's a yes or a no, positive, negative. So I think at this point, we're not really close to herd immunity. We're going to need a vaccine for us to really get immunity. So really the bottom line is the masks, social distancing, washing your hands, like we were all talking about. But hopefully we will get there soon.
Yeah. All right, great. Thank you. All right.
And I think the science will speak to that as well. I think there's a lot of studies, that are out there just looking to see. I know Rutgers is doing a huge national study where they're looking at the healthcare workers, and they're looking to see if they build up immunity, and if so, how much immunity is good enough. They can, so that's in the makings now. As I said, as I've been saying, I think that the science will help guide the treatment. But those studies have not come out yet. They'll be out soon.
Something that I'm just going to add in, something that Hackensack is doing or has been doing is plasma studies, where they're taking convalescent plasma from patients who had tested positive. They're taking that blood and then transfusing patients with COVID. And that's also proven to be very successful. I don't know if every hospital is doing it, but it's something that Hackensack does.
All right. Yeah. Thank you so much for being with us, spending time with us, answering our questions, and also answering the audience's questions. I think that both your perspective, your experience with the COVID-19 crisis, but also the fact that all of you guys have such varying backgrounds and different ways of looking at it was really insightful, and really gave, I hope, all of us a really great insight on what you guys actually do and experience day in, day out as medical professionals, but also as people, as, moms, and, when you think about as a parent and as an educator. Yeah. Natalie, do you want to add anything?
I think you got it. Yeah, thank you so much for taking the time with us. I learned a lot, and I hope that everybody here also got a lot from it. I love hearing the human side of it. I think it's the fatigue. Honestly, like, we're feeling the fatigue, right? But this is just an excellent reminder that we just have to keep pushing. It's just better for everybody. We'll get through it, and you guys are just proof of that. Dr. Agapito, do you have any closing words you'd like to say?
Thank you all for being here tonight. This event was very informational in terms of learning more about COVID-19, learning about the experiences of our medical professionals. And I would like to extend my deepest gratitude to all the guest speakers. Thank you for making the time. Thank you for actually saying your stories. There's so much out there in the news, and sometimes it's so confusing. But today you did a difference. You communicated what you went through, and what best, the ones that are actually seeing the COVID-19 patients. As part of the New Jersey Academy of Science, and the whole team, thank you with deepest of my heart.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you for having us.
Thank you for having us.
Thank you.
Have a great night.